Hi, I'm Mohanan. I'm a cardiologist from Thrissur, Kerala. And my topic I was presenting in today's session was on the importance of revascularization in ischemic cardiomyopathy. In fact, it was a debate. It's a debate where I am vouching for PCI, and I will opt for PCI in as the method of revascularization in ischemic cardiomyopathy. Well, if you look at the data, now there is again a debate on is revascularization needed in ischemic cardiomyopathy. But then we have sufficient data which tell us, including the ischemia trial, one of the greatest trial in cardiology, which tell us the importance of revascularization in subsets of patients with coronary artery disease, LV dysfunction. If you look at the guidelines, you will see that there is some differences from across the Atlantic. The USA says that CABG is the best option for ischemic cardiomyopathy. No mention about PCI. While the ESC gives a class 2A recommendation for CABG and a class 2B recommendation for PCI. Unfortunately, now the mode of revascularization, whether it is CABG or PCI, which has to be done, is not yet decided. We have some data, and for example, the guidelines, which are not guidelines, are based principally on the data from the STITCH trial, which was done at a time when the optimal medical therapy was not the best. And that showed, despite an increase, almost 3 times higher mortality in the initial period, if you follow them up for the next 10 years, the 10-year data suggested that CABG has an edge over medical treatment in form of overall mortality, cardiovascular mortality. So that was, STITCH was a randomized controlled trial. That was possibly the only randomized controlled trial in deciding the superiority of CABG over optimal medical treatment. But I told you about the limitation. Well, when it came to PCI in ischemic cardiomyopathy, we have the REVIVE BCIS2 trial, which was presented a couple of years ago. That was again the first RCT comparing PCI versus optimal medical treatment in patients with ischemic cardiomyopathy. But here, despite the very many limitations and controversies on this PCIS trial, REVIVE trial, about the long recruitment, patients, almost 2/3 of the patients having no angina, significant angina. This was a neutral study. So now we have two, the STITCH versus the BCIS study, the REVIVE data, which says STITCH shows an advantage for CABG and REVIVE shows a neutral benefit for the PCI. Again, we have to be very clear in our mind. The REVIVE data of PCI was not done with any imaging, with any other CTO special squad or the heart team training. So there are, and mind you, there never is a trial which compared CABG versus PCI in patients with ischemic cardiomyopathy. So we are going to see in the next couple of years, or maybe by 2027-28, we will have the STITCH-3 data, the SET-HEART data, and a couple of other trials which directly compares CABG versus PCI in ischemic LV dysfunction. So why I am supporting PCI in ischemic LV dysfunction is based on a couple of other trials like the PROTECT series of trials, the Restore Heart Failure trials, which has done PCI in the optimal condition with imaging, with inotropic support, not with inotropic, but with mechanistic support, either Impella or IABP or even MCS. So if we do the optimal PCI in patient with ischemic LV dysfunction, it could be as good as CABG. Thank you.